I'm delighted to introduce Gabrielle Parham this afternoon. Gabbie is a district nurse and Queen's nurse working as a senior matron for the community nursing at Oxford Health NHS Foundation Trust. Gabbie is vice chair of the Community Nursing Executive Network and ICB lead for community nursing on NHS England Primary and Community Nursing Group, and has recently won the British Journal of Nursing Sustainability Nurse of the Year 2026. Gabbie's going to be talking about comprehensive reviews for patients on insulin, focusing on how continuous glucose monitoring technology can support more effective personalised care. Over to you, Gabbie.
Thanks very much. Could you share the slides for me, please?
Absolutely.
Thank you very much. And thank you very much for inviting me to speak at this. It's been really interesting listening to the other presenters. I'm delighted to be here today. So why did we choose this project? So nationally, there's a district nursing service capacity and demand issues. It's very acute in Oxfordshire. We have around about a 28% funded capacity to demand gap. We visit probably about 1,100 patients a day on average, and we defer or cancel a further 300 to 700 visits a day. The sort of resources involved are travel, the actual medicines involved in insulin, equipment, admission to hospital, and ambulance journeys. So for these patients on our caseload, they make up around 33% of visits of people that need help for us to administer their insulin to them. Many of these patients are housebound and are unable to have their annual diabetes review at their GP surgeries as ambulatory patients might. There was real potential for inappropriate and unsafe patient treatment because they weren't having continuous blood glucose monitoring. A real lack of parity of esteem for housebound people and the potential use of unnecessary resources. Next slide, please. So we decided that our patients on the caseload really needed a thorough review. So we engaged with GP leads. We sent a letter and approached 3 GP surgeries to see if they'd be interested in us reviewing the patients with our community diabetes specialist. And we'd also discussed it with both the hospital and community diabetes specialist beforehand. We'd engaged with patients and relatives about the review and the outcomes during the project, and the SusQI team for all the carbon footprinting and financial calculations around sustainability. What we did during the reviews, we had quantitative measures, which was around the clinical outcomes for the patients and the carbon footprinting and the finances, and also qualitative surveys of the patients, relatives, district nurses and practice nurses involved. We found that when we approached the GP surgeries, actually they wanted to review the patient with us rather than us using our community diabetes specialist, but our community diabetes specialist offered support and a sort of, for this pilot, a double check of the decisions that were made. Next slide, please. So what we found is when we applied blood glucose monitoring to patients, instead of that one finger prick before we would normally give their insulin a day or possibly twice a day, we either put continuous or flash blood glucose sensors onto the patients, and then we had a 24-hour profile in order that the practice nurses could do the review. What we found was 27% of patients were having low blood sugar, hypoglycaemia, which is a life-threatening emergency at times of the day when normally district nurses wouldn't have been visiting, for example, 3 a.m. in the morning, that were unknown prior to this project. And 43% were experiencing high blood glucose or hyperglycaemia, which gives you an increased risk of infections, discomfort, and potential emergencies as well. 77% of the patients required a change to their insulin treatment. 37% had a reduction in their insulin, 37% an increase in their insulin, and 7% would discontinue their insulin and became independent with their diabetes management with oral drugs. The impact for patients were that 94% felt that the review had a positive impact. They reported improved quality of life and independence. One quote was, "I have better control of my diabetes. I am now independent and can go out now when I want." And they've become self-caring. They were also more in control of their diabetes, and it put a focus on what they were eating. One of the patients commented, "I changed my eating habits and I'm now able to monitor my glucose on my own," because they could see the real-time effects of what they were eating on their blood glucose. And there was also improved safety, particularly related to hypoglycaemia. One of the patients commented, "I had no more hypos. I used to have hypos every morning, but I'm now okay since the assessments and the sensor." Next slide, please. So what was the impact on the service and the system? So there was a 12.5% decrease in insulin administration demand, either by people moving from once daily insulin to once daily or being taken off insulin altogether. So out of 30 visits a day for the cohort of patients we did for this trial, 4 visits a day were reduced. And that means with our capacity and demand gap that 4 other patients who would have had their care cancelled or deferred are now able to be seen every day. When you extrapolate this across the service, that could lead to a 40% reduction in deferrals of high priority patients that we're currently deferring. For example, people requiring wound care. So there was a reduction in risk to other patients on the caseload, not just this cohort of patients. With our carbon emissions, initially there was an increase in carbon emissions and financial costs due to the sensor application, which is more expensive and has more carbon output than the finger prick test that we were doing before. But if we just use the sensor for the reviews intermittently and then reverted back to the finger prick testing, we start making carbon savings at just over 76 days point, and we break even at 110 days financially. So therefore, over the first year, you're getting significant environmental and financial saving to the whole healthcare system. We're not able to measure what hasn't happened because it hasn't happened. And we weren't able to track the patients before and after this so far. This is something we would like to do, but we just haven't had time. But the risk of the cost of hospital admissions financially, environmentally, is also reduced, because if you're having hypo or hyperglycaemia, there's a much higher risk you were going to be admitted to hospital or use ambulance transport. So it's reasonable to assume that there would also be carbon and financial savings on the rest of the healthcare system as well. Final slide, please. Thank you. So for future sustainability of this project, we're aware since we've done this project that there is other national projects going around under the GIRFT, for example, GIRFT project around this, very similar to this. We feel what is good about this particular project in terms of sustainability is there's no upfront investment. We were using practice nurses who were already employed, and our community diabetes service and our district nursing service that are already funded to do work around this area and just working together in a different way. So there was no actual direct financial cost to staffing to do this. It's easily replicable in our other teams, and we're now currently rolling this out right across Oxfordshire. And I'm monitoring the results for that, and we'll calculate up the carbon and financial savings and sustainability from that there at the end of that. And obviously it promotes the NHS 10-year plan around neighbourhood team collaboration and integration between different providers in the community. And that's why it was also good to be working with our practice nurse colleagues. And that's my presentation. Thank you very much for listening.
Thank you very much, Gabbie. That was amazing.